So infectious diseases, I don't know if you guys are aware, we're a relatively small team. We have a single ward, Nightingale ward, at City Hospital, which is a 13-bedded ward. We get some interesting scenarios as a specialty because we deal with a lot of challenging patients, lot of tricky ethical and clinical scenarios as well. Not and my experience from doing simulations with the Sim Center has always been around more acutely unwell patients, CPR, and human factors around medical emergencies. But one thing we chatting to the staff on Nightingale ward, we found that well, the primary issue that we found was there was a lot of issues around staff retention and nurses. I think that's a problem across the board. But Nightingale was having a really rough time holding on to our good nurses because people were leaving because they couldn't find somewhere where they were upskilling. Because for hematology, for example, they have hematology nurse specialists, and they can see a clear a pathway for them in terms of progressing. Whereas ID people do the job, they come in, they do a really good job, they're amazing, they work really well with these tricky patients, but then they go, where am I going from here? And their option is to leave. So we were trying to kind of explore what are we missing the trick? Are we not really spending much time with the staff as a team? And in terms of upskilling them and making them more comfortable and confident with what they're doing. And and from that came up an idea to try some simulation to try and educate and have conversations around what you guys as Nightingale, the nurses on the ward, are doing that's very different to what anyone else can do, and from a skill set perspective, and giving them that confidence, but also upskilling them in some way, which is not the aim of simulation in the first instance, but identifying things within a team, how we can improve, and especially around human factors. So that's a bit of the why, and sometimes things happen that we aren't prepared for. And just to give you an example, like it was middle of last year, someone got tasered on our ward. So it doesn't happen. It's not a normal occurrence. We've had patients climb onto roofs and throw roof tiles, and that probably might be the next scenario we're going to get Paul Bailey to do is climb a roof. But we get challenging situations, and to try and capture some of the main themes, and this is just a big box of themes, really. It's one of the main things is infection control, because it's one of those things where if you get it wrong at the offset, you can expose people to things which they shouldn't be exposed to, and having to think about it. And there's lots of things that we do by putting people in side rooms and your physical door as a barrier. But people have become numb to that idea on our ward because it's a door and it's just another room kind of situation. So how can we make people to think about what they're doing before they actually go into a room and why they're going into a room? Is it necessary to go into the room? And trying to get the multidisciplinary team on the ward. So initially it started off as just nurses, but I think we branched out to dietitians, receptionists, healthcare assistants as well. We've put in a bit of medical emergencies as well, because that happens. Anaphylaxis is a problem that with antimicrobials, especially from an infection perspective, we want people to be ready to deal with. So we kind of put that in as well. Confidentiality is a tricky one. We get lots of phone calls from random people asking history about someone on the ward, and that's a family member with HIV, which you can't really break confidentiality there if it's not a risk to them. Lots of stigma and dynamics around it. So how do you manage a situation where confidentiality has been breached, for example? And I'll show you some examples of what we've done scenarios wise. Needle stick injuries. Again, if you were to get a needle stick injury, Nightingale ward is the worst place to get a needle stick injury because it's a concentration of your high risk patients. But at the same time, we sometimes have colleagues from different wards come to your high risk ward going, can you help me? Because this has happened. You guys most probably have dealt with this 100 times, but are we actually confident in kind of dealing with the clinical side is one thing, but actually dealing with the person at that moment in time? How are you supporting that member of staff? How are you signposting them to the right places? Are you taking all the necessary prompt actions in the middle of the night? Because this can happen at any time. And I've had calls from the nurses in the ward saying, someone from Barclays come with a needle stick injury, what do we do, kind of thing. So how can we kind of make it normal practice for Nightingale to be kind of a place where people can come for support in that instance? And of course, these things happen when someone's sick and running around the ward. It doesn't happen when everything's calm and quiet on the ward. Language barriers is a big thing, and I know it's a thing that's on the agenda for lots of areas because how good are we at taking good history from patients who don't speak English as their first language? Are we good at addressing their concerns? It's a big risk, and how much are we understanding that it's important that we break those barriers around language, especially with all the tech that's available now and Google Translate and AirPods that translate for you live and whatnot that's around there. We see a lot of drug errors happening as a result of some patients being admitted directly from ED to the ward, because if it's a malaria patient, sometimes we say, look, we'll get them across to Nightingale directly rather than coming through an admissions pathway. But what that means is that sometimes in ED, medications that are prescribed for a specific infection like malaria cannot be prescribed properly because they're like, oh, they're going to Nightingale, but not understanding it's a time critical medication. But when you receive the patient, are we going through a process of checking, is everything being dealt with? There has been staffing challenges. I think it's because it's a 13-bedded ward. It's one of the places where they go, you guys are fine. We'll take someone off you and move them somewhere else. And the nurses go, but I've got someone who's threatening to break everything in the ward and someone who's falling over every 2 minutes. How am I going to man this ward by myself overnight? So there's that aspect as well. Um, AVH is something that's kind of grown with this sim. I don't think it was the intention initially, but I think it's kind of developed as we went on. Uh, we have a lot of it, a lot of verbal abuse. Our nurses are unbelievably resilient against these things, uh, but there are levels to it, and I think that's one thing we wanted to kind of explore as people's comfort. We've got body cams on our ward now, how people utilize it, how they understand what to do, who can they call for help, how to position yourself in a room. It's something that you need to be in the scenario to understand. They do like your training around if someone holds your collar, what to do and things, but it's not a jujitsu lesson. It's how you manage a situation, how do you de-escalate, how not to say the wrong things to a patient, and identifying which patient to say what and how to treat them. Because there are some patients where you need to be very firm and aggressive with, but there are some patients that you do that, that's the end. You're just going to lose them, and they're going to just escalate and escalate. So how do you navigate a scenario like that and how you can get people involved. So these are the general themes what we were looking at, and this list is kind of growing as we've done the Sims. Uh, so this is just an example scenario. I don't know if you guys can see it very clearly, but you can zoom in from the bottom left corner of your screen to read the scenario. So this is, I wouldn't say these are common occurrences. These are things that can happen, and it can happen suddenly, but it's being prepared for that instance when it does happen. So this was just a scenario that kind of came up with about someone being admitted from clinic, and there's some uncertainty around whether they need TB precautions or not. Are they compliant with treatment? Because it's quite easy for us as medics to say someone's, oh, they're smear negative, smear positive, which might make sense for us, but what does it mean to the entire team? Does everyone in the team, including the person who's serving food, know what that means? And the aim isn't not to teach them about TB, but for them to think about, how do I question this before I go into a room? Should I be worried or not? Um, and that's something we try to incorporate with different varying types of transmissible infections. And TB exposure isn't pleasant. If you get exposed to someone with high risk TB, you're going to probably need testing and follow up, and that causes a lot of anxiety around that. And one of the challenging things is patients wanting to leave the ward, come back in. How do you manage that conversation around, we don't know what to do right now? We can call for help and ask the ID on call doctor, or is there something within our team that we can actually make a decision on, a clinical decision? Because at the end of the day, you are nurses working on here. So how can showing them the right resources to look at, and this kind of has prompted a lot of discussion. So this is just one example. There was another example, I don't know if I've included on these slides, just go on to the next one, is drug errors and allergy. Just about PPE as a thing is that patients family members want to visit, and that's always a very tricky area to navigate. And how do you make that risk assessment at that point in time? So kind of having a bit of a thought process and information gathering in the offset. And then when you call and speak to someone, you have all the information. There's no back and forth because patients and families can get quite agitated and angry when you're like, you're not going to see your child who's 4 who wants to see you, and there's a kid wailing outside. So those things are very tricky to navigate, but having it in a simulation setting, I guess, kind of gives you an idea of what your thought process is and makes you think about what can you do in the future if it was to happen. So that was kind of the aim with these scenarios, and we've kept it fairly busy. And I think the sim team have helped to go, this is ridiculous, Roderick. We can't do all of these things to someone because we try to send 2 or 3 people together so that there is a bit of support, a bit of mixed skill. One thing that I'll go on to talk about is um, who attends the sims. I know we mentioned there's a lot of MDT, but one group of people that we're missing is medics, and that's quite hard to pin down, primarily because the what we're trying to explain here, what we're trying to understand and explore is not around the clinical scenario, and sometimes when a medic gets involved, it becomes very clinical very quickly. So we are kind of trying to figure out how is the best to approach this with getting some medical input. Feedback, as always, I'm sure the sim team always get good feedback, but it's really good. Everyone values this. I think everyone wants to keep doing it. We're looking at dates for next year as well. Very positive feedback as to how it went. We started off the simulations as a sim within the sim center, and this year we did it in situ, which is on Nightingale itself for the first time. And we kind of have the setup to deliver that, which worked really well. So that's been taken on really positively, and I think we're going to stick to in situ simulation. So that's just feedback. Um, the yeah, that's more feedback again, all relevant and positive, and everyone rates the actors from the sim team because it feels genuine. There was one person feeding back saying the person who was being aggressive and violent should break more things. I was like, that shows how, how much of a threshold we have. So I think the next one we're probably going to have some props which can break repeatedly over multiple sims. But so yeah, that was basically a summary of what we've done within infectious diseases. Challenges are getting rotors and data availability. It's not easy from because the sim team are in demand, and at the same time getting staffing right on the ward so that people can be freed up. And I think we're trying to highlight that as a priority to the division as well to say, look, you need to let people go and do this because this is really important. This is things like AVH doesn't only happen on Nightingale; it happens across the board in ED, in any other ward really. And I think it's useful for teams to be kind of prepared in that sense. And I think this is a really powerful way of kind of showing it. Uh, the catch is, I think, the fine line between traumatizing someone and giving them the experience to understand how to navigate a scenario. So I think that's a fine line, and it's a constant conversation with the sim team going, is this okay? Is this not okay? And them giving us feedback, which is really useful. Medic involvement, as I've mentioned, new scenario development actually initially I thought was a challenge, but I think more people have come attended it now, and they've gone, oh, this is useful to explore this and this. Um, Couple of things we picked up from the actual Sims itself was like things around hierarchy. How if there's a medic that turns up, everyone stops thinking what they're doing because they feel like, oh, it's someone else's problem. But actually, that member of staff might have something valuable to add to the patient's care because they probably know more about that patient. Um, and recently, we've had family members adjusting the IV drip when there's potassium in it and all sorts of things. So scenarios like that, you're not going to experience it. You don't want to experience it for the first time on the wall because it's just going to be like, what am I going to do? So it's useful to have it in a sim setting where it's safe to explore. And expanding beyond ID is a conversation that we're having with the sim team now. It's how do we expand? And one possibility we're looking at is our OPAT team, so the outpatient antibiotic team. They deal with a different set of challenges because it's a kind of a community setting, but they do go into people's houses by themselves to administer stuff. Um, so is there a way of doing that and incorporating them? So those are the kind of things we're exploring moving forwards, because there is again some skill set that we feel that it's and keeping to the idea of themes in these scenarios is the main thing. But hopefully we'll design some scenarios going forwards. And yeah, big thank you to the Trent Sim team because obviously it won't happen without them. But I think they've been really helpful, and I think the ward teams are just very grateful. I think it's a very different way of training and learning, and it sticks with them forever. Interestingly, we have governance meetings in our ID department, and we look at datixes and incidents. And one of our actions is, oh, we've already done this in our sim. We've trained against it. Like there was a needle stick injury, and then people didn't know what to do. We were like, oh, this can be addressed as part of our kind of one of the things, along with all the actions that you would normally do in a governance process, is that we're looking at training and we're looking at these scenarios. So I think there is a back and forth between there as well. Um, and all these scenarios where people get tasered and glass breaks and things, security arrive, there's a lot of learning around those individual episodes that we can translate into the sim as well, which again, it's training for the generations of members of the team to come on Nightingale. But that's everything.